Welcome to the Center for Risk Analysis, where we help you to understand the risks in the present environment, to prepare for an uncertain future, and to prosper tomorrow. My name is David Ansara, and today we're focusing on the healthcare sector and specifically the National Health Insurance Policy proposal. There's a bill that has been knocking around Parliament for several years now, which will dramatically alter the health funding landscape in South Africa. And I'm joined today by Mike Settas, who's a healthcare specialist who's active in the health insurance space. Mike, welcome to the Center for Risk Analysis.
Thank you, David. Thanks for having me on board.
Mike, we are the Center for Risk Analysis, so naturally we're focused on risks. So what do you think are some of the risks associated with the NHI policy? And perhaps if you could also just give an overview of how NHI would be structured under the current proposal.
Oh, yes, excellent point around that. I mean, just to touch, you mentioned earlier, you said the proposal's been around for several years. In actual fact, this thing's been around for 11 years. So that's how long NHI's been knocking around. And besides the fact that we don't really like the content of it, much of it is, not much has really been built around it for such an extensive period of time. But the key risk, I mean, if we do look at the risks around this thing, both the funding and provision of healthcare is being proposed to be centralized at a level of national control. Now, that in itself creates massive risks. On the funding side, we are looking at the potential, given South Africa's history, given where we are now, for massive corruption in a system of this magnitude. I mean, we're talking about an entity that's going to be hundreds of billions of rands in turnover. If we look at the provision side of it, we look at international best practice has largely all around the world moved away from centralizing the delivery or the decision-making at the clinical level in care, because it doesn't give you the outcomes that you could achieve where you decentralize the thing. So both on the funding and the delivery side, the proposals really are not best practice as to what's practiced around the world. And those really are the key risks, besides a few others, which we'll maybe touch on later, but really those are the two massive risks around the NHI proposal.
Thanks very much, Mike. I mean, I think also given the parlous state of South Africa's public finances, if I recall a year or two ago, the Davis Commission, the tax commission that was looking into the overall tax profile in South Africa, made a pronouncement on NHI to say that unless South Africa was experiencing growth north of 3% per annum, that from a fiscal perspective, NHI would be unsustainable. And if you consider that we now have a 700 billion rand deficit, the largest deficit we've had since World War I, it doesn't seem to me that from a fiscal perspective that NHI is really a going concern. But what do you think are the prospects for NHI being implemented in the short to medium term, Mike?
Yeah, I think that to look at the fiscal issue, I mean, clearly we're in unprecedented territory now. But even if we say unwind or rewind a bit and look at where we were, so maybe prior to the lockdown, and the economic impact there, even at that level, we didn't have the fiscal space to build the NHIs they're proposing. Because I think we have to remember that the policy around NHI has always been that it's going to be comprehensive care, so a comprehensive package, and it's going to be free. Now, we're talking populism here at its absolute best. So I think post the lockdown, there's the obvious economic impact that this has had on the country. The extent to which the government's promising, there's no chance that they're going to be able to get to that level in terms of the proposals that they're putting together. So I do think that what potentially might happen is that a more watered down level may come through. And I think it also depends largely on what happens within the factional fighting within the ruling party. And I think if we see Cyril and Tito and that faction gaining ground, I think we will move towards more pro-private policies. They may not explicitly go away from NHI, so it might still remain as a policy, but I think a lot of the stuff internally may change. So we may see things like medical schemes may not be too largely affected, that they can remain in parallel to NHI rather than falling away. And then I think the other thing is that the governance structures in the NHI, the way they're drafted now is very poor. They give total control to the minister. Whoever holds that post will have control virtually of all the committees within the NHI. And those committees have substantial power. You know, they decide who accredits which doctors, how much they get paid. So you can just imagine, you know, given our history, the extent of potential for corruption in a process like that. So I think that governance structures will be revisited. But again, I say it assumes where the political play pans out over the next year or so.
Yes, and obviously the current ructions within the tripartite alliance and the internal debates around corruption, I think, will bring this issue to the fore. I think another individual to watch would be Olive Shisana, who's a special advisor to the president on healthcare matters. She's a public health expert who's been driving the impetus behind NHI, as well as the health minister himself, who's recently made comments in support of reviving NHI. And what we might see is that the COVID crisis is used as a way to justify ever-growing state centralization, and the risks associated with that are well known. If you look at many of our SOEs, we could have NHI being akin to the ESCOM of healthcare, which would have some serious consequences for the provision of healthcare funding, but also healthcare services. Right, Mike, well, what are some of the alternatives to NHI? It's being sold as this silver bullet solution or a panacea for many of the healthcare problems that South Africa currently faces. But what reforms to the existing system could be made, both on the private healthcare side and on the public healthcare side, that would crowd in the private sector and improve the quality of healthcare provision?
Yeah, I think just to touch on the point that you used the silver bullet, I think it's very relevant because there was actually a headline last year in which Dr. Mkhize used those exact words, that the NHI proposal is the silver bullet that government is looking for. However, the real big problem there is that this is one of the biggest proposals that sort of post-94 South Africa has ever put in place. And yet there's been very, very little technical analysis. There's been no costing on it. So, you know, it's unfortunate that government talks in this sort of term, and it does kind of make you think that it is just a populist mechanism rather than any real decision to reform. Obvious concern is that they do go down this road. So I think the issue of looking at alternatives, I think that's important because I think we need to go back to the question of why is this proposal on the table? And if we look at it rationally, South Africa has, if we look at the private sector, we have a world-class private sector. We also have 9 million people who are willing and able to pay for their own healthcare, which means it alleviates the state from having to look after them. And there doesn't seem to be any rational reason to take that away and say, now the state is going to take over, because this adds to their liability, which really doesn't make any sense. Government spent 200 million rand on the health market inquiry, which the competition undertook over a space of 6 years. And that's, it's an evidence-led proposal to reform the private sector to really make it more cost-effective, which then in and of itself will expand the private sector and means we have less people relying on the state. If we go back to the state itself, the public structure that we have now is actually very good structure. I mean, and I don't see any need for the reform of this. It has worked well in the past. And the real damage to the system that's been done now is really comes down to what's probably the issue for most of the South African public service departments is rampant corruption. If we read the Auditor General's report on the Department of Health year after year after year, they record one of the worst audit records of any department. And that is really what has sort of destroyed the capability of the public sector to deliver healthcare. It's not the structure that's the problem. If we can eradicate the issue of corruption the graft, the appointments of people who aren't qualified for these positions, then I really think we would have a pretty good health system. And I think, if we can aim towards that, I think we've got a win all around.
Yeah, and Mike, I think one of the regulatory areas in which the healthcare system could be improved is revising this issue of prescribed minimum benefits. The intention behind that is to say, well, healthcare funding providers need to have a foundation, a base of services that they cover, but that in effect crowds out many low-fee private healthcare providers. What are your thoughts on that?
There's there's a lot wrong in terms of the regulatory structure in the private sector. And I mean, the Health Market Inquiry emphasised that. They in their just in their opening few paragraphs in their final report, they wrote that we sit with a half-baked private sector regulatory structure, and it was never really the intention to have that. But for various political decisions in the late 90s, that is what we got. So because of that, we've seen things like the prescribed minimum benefits being blamed for where the cost structures are. But in essence, it's not a bad principle to have a prescribed minimum set of basic care, as is the case. The problem is that some of the stuff wrapped around it, like that they must be paid for at cost. So this gives license to providers to charge whatever they want, should something be a PMB, or in the worst case, even intentionally code something as a PMB just so that they can do that. And that has really had a massive impact on cost in the private sector. And I think if these things can be looked at, if there's the political will to do this, then I think we can get those sorts of things fixed. They are fixable, and I think that was a key point of what the HMR, the key point that they added is it's not a terminal scenario. If we go through these reforms, we can fix the system and get ourselves back to a more sustainable trajectory.
Mike, thank you very much for your time and your insights. I think that you have some very sensible proposals there. And yeah, I think the nature of policy is that in many ways it is downstream from ideology. And this idea of a massive, highly centralized platform that would solve all of our problems, I think we should treat that with quite a lot of skepticism. And I think the devil's in the detail in terms of the granular policy issues where reforms could be made quite easily. If you benefited from this video and if you enjoyed our insights, please do give us a like and remember to subscribe to the CRA YouTube channel. But also, we are currently running a 30-day free trial. So if you would like to benefit from our reports and our briefings and our analysis, please do follow the link in the description below, and we'd be happy to share with you some of our information and insights. But until tomorrow, take care.